Hello, everyone. Happy Thursday. I'm Michael McNutt, Director of Education and Events for WEDI, and welcome to our Member Position Advisory from Crisis to Continuity, Maintaining Healthcare Data Exchange Following a Cyber Attack. It's my pleasure to introduce Robert Tennant, Vice President of Federal Affairs with WEDI.
Thank you, Michael. Let me add my welcome. We have a very packed agenda for today, but to kick things off, I wanted to turn it over to our current board chair, Ed Hafner.
Okay, thank you, Rob. We should have the agenda popping up here. So today we'll have a quick welcome for about 10 minutes. We'll be introducing our facilitators, which are a wonderful group of people representing many stakeholders. Then we're going to be going into, of course, the discussions on potential recommendations that we will be provided to Health and Human Services, and then we'll do a quick wrap up and let you know what those next steps are. I want to talk a little bit about today's event. With WEDI being named as advisor to Health and Human Services in HIPAA law, we originally created a process called Policy Advisory Group, or PAG, where we all got together, discussed a particular regulation or a particular topic. We would vote with our little red cards, one card per organization. And of course, when COVID hit, and we wanted to be able to spin up more feedback from membership, Bob Bowman and Jay Eisenstock, along with Nancy Spector, created this new process called the Policy Advisory Group, Member Position Advisory, which we've gone ahead and done it virtually, and we can spin it up much quicker, and it's been very, very proactive for us as we were able to create a lot of feedback to the Health and Human Services. We often do surveys, or we can do online surveys. Today, our panelists will be discussing a lot of the topics, but please use your chats today. Your chat button will go ahead and prompt the discussion, and hopefully you also can provide some input. We take all of it and form hopefully a nice a memo to Health and Human Services with our proactive suggestions today. The end results is reviewed by the WEDI board, and then that would be the official WEDI position. I do want to take a quick thought on what this topic is today. Recently our U.S. healthcare system was targeted with a very strong ransomware attack on just one company. However, the impact was felt by many providers, health plans, other vendors and services, and certainly patients who affected their online prescriptions. There's some financial implications on understanding what kind of claims would be paid. Prior authorizations was a question. Eligibility experience was a question. Many other experiences were impacted by this. And that was just by one company. And the cyber attack, from what I understand, came from a third-party IT support tool that had a security leak. And if you're in IT, you know that most of your software companies will issue security software patches throughout the year. And so there's vulnerabilities that are being discovered all the time. So in other words, this could have happened to any of us. It could happen to your direct vendors. It could happen to you directly on your systems. It could have been happening to other services like the one that just happened. So we're looking forward today. We're not going to be talking about what happened just recently, like the Change Healthcare Optum situation. We're going to say, what if this happened to you? What if this happened to you as a provider? What if this happened to you as a payer or a government agency or a vendor service? What do we need to do to be better prepared as an industry and as you yourself for the next one? So because quite frankly, we're most likely going to see more of these attacks, unfortunately. So we're going to develop some recommendations today from WEDI membership. Please be very, very active in your chat. Rob will tell you how to do that in a moment. And your strong voice will be heard today. So please make that loud and clear. Rob, now to you.
Thank you, Ed. And let me reiterate that we're not here to point fingers at anybody. We're really trying to identify some opportunities to ensure that data continues to flow And obviously we're focusing on cyber incidents, but this could be a natural disaster as well. Anything that impacts computers is fair game. And as Ed said, this is your unique opportunity to share your questions and your perspectives with the entire WEDI membership. So use that chat feature. And just as a reminder, we'll send all the slides and the recordings from the event to everybody who registered for the event. So you'll get those in your inbox fairly shortly after the event. Next slide. So let's jump right into our introductions of our facilitators. So I think if you go back to the agenda slide, Michael, we'll run down the list. So let's start first with Leslie, and then we'll go to Terry.
Good afternoon, everybody. I'm Leslie Berkeyheiser with Direct Trust, also one of the Privacy Security Work Group co-chairs at WEDI.
Hi, I'm Terry Cunningham, the Director of Administrative Simplification Policy with the American Hospital Association. I'm also one of the co-chairs of the WEDI No Surprises Task Group.
Excellent. Then Beth, then
Good
Stephen.
afternoon. Hey, I'm Beth Davis, Senior Manager MPMP at Payer Path Paradigm. I'm co-chair of the No Surprises at Task Group and the WEDI Claims Subgroup Group.
I'm Steve Hughes. I'm the Director of Health IT Policy at the American Hospital Association.
Great. And I don't know if Trisha is on yet. Okay. So we'll go to Mike and then Pam.
Hey, I'm Mike Green. I'm the Chief Information Security Officer at Availity.
Hi, I'm Pam Grosset. I'm Lead Product Manager at PNC Bank. I am also on the WEDI board and co-chair the Remittance Advice and Payment Subwork Group within WEDI, and I am the board chair for the Cooperative Exchange.
Great. And let's go Sherry, then Danielle.
Hi, everyone. I'm Sherry Holmes Henry. I'm Vice President of Government and Industry Affairs for NextGen Healthcare. I'm also the past chair of the Electronic Health Records Association, sit on that executive committee and on the WEDI board.
I'm Danielle Lloyd. I'm Senior Vice President for Private Market Innovations and Quality Initiatives at AHIP, the trade association representing health insurers nationwide, and I also sit on the WEDI board.
Excellent. Then we'll go Stanley, then Tan.
Stanley Malcolmson, the principal of Malcolmson Advisors, an independent consulting firm. I'm also the co-chair of the WEDI Claims Subwork Group and the No Surprises Act Task Group.
Hi, everyone. I'm Tan Nguyen with Kaiser Permanente, and I'm in the Health Information Technology Strategy and Policy Group, and also one of the co-chair for the Privacy and Security Work Group with WEDI here.
Excellent. So we're going to go right to our first poll question. Michael, if you could pull that up. So we're going to ask which stakeholder group best represents your organization. So health plan association, provider association and clearinghouse, software vendor, health information exchange, if you're a patient advocacy group or other vendor or consultant, and then government, and then other. So we'll see. Looks like we've got a good mix of folks on. We'll leave that open for just a couple more seconds. And again, we won't bother you with too many polls, but we do want to get a sense of who's joined us today. Okay, so it looks like, again, all right, I think that should be good, Michael. I think we can go to poll number 2.
Having a little bit of a technical situation here, Rob. Give me a sec.
Yep. No worries. Just as long as we weren't hit with a ransomware attack, I think we should be in good shape. So
Not at all.
And if we can't get them to work, Michael, we can skip over the.
They actually are working. I just can't seem to advance the next slide.
Okay.
But yeah, the poll is up for everyone. All three questions are up at the same time.
Gotcha.
And they're all answering them.
Okay. All right. Let's skip over then. Yeah. Okay, so we may be able to get back to those polls, but for now, let's I think we just had the one poll question, but the other questions were really essentially has your organization been impacted by a cyber incident in the past 12 months? So feel free to use the raise your hand feature to let us know. But I suspect most of the folks that are participating today were impacted, if not by the Change Healthcare incident, certainly by others. So yeah, we're seeing some hands. And then the other question we had was really around the idea of how important is it within your organization to develop a contingency plan or disaster recovery protocol, especially in light of the recent Change Healthcare attack. I don't know, Michael, if you can pull that one up or if we just want to move ahead.
I think I'm going to try to relaunch.
Okay.
All right, folks, I'm going to relaunch. If you can scroll down once you finish answering the first question.
Oh, okay, gotcha. Yeah, so just all three questions are in the same window, so just scroll down, you'll be able to answer them. So there's a few folks that weren't impacted, but the majority are saying they were impacted by a cyber incident. And again, not surprising, we're hearing that the importance of, again, creating a contingency plan or disaster recovery protocol is very high priority or high priority for almost all organizations. So that gives us, I think, a good glimpse into what folks are doing internally. So let's go to the, I think we can end the polls and let's go to the next slide. So we're going to kick off our discussion today on the health plan side and talk about some opportunities to reduce burden either during a cyber incident or right after one to try to make sure that providers can continue to see patients and make sure that their revenue stream continues. So I'm going to have our facilitators raise their hands if they wanted to make a comment. I know we had a prep call and there was a lot of discussion around the opportunities for health plans to address these types of issues. So one of the issues, of course, is where many providers and health plans are reliant on their clearinghouse partners. And as Ed talked about earlier, when one goes down, it can dramatically impact data exchange. So we'll start off with Danielle.
Thanks. I think recognizing we're not specifically talking about the change situation, but using that sometimes as, examples type of thing. The health plans did almost immediately, like over the weekend of the first, situation, communicate to providers, what sort of temporary workarounds and such they were doing, because there was sort of that Band-Aid phase and then the more temporary solution phase before we get to the restoration phase, right? So that early on, but I think what we've heard, which is evidence in the slide here from providers, is there's really a need to over communicate and perhaps use as many channels as possible, because while there were communications out there, not everybody was sort of getting and absorbing that information. So I think that is definitely, sort of multi-channel is a lesson learned and a takeaway. I would also say, though, communication is a two-way street. A lot of the plans, or most of the plans, increase their call center volumes, anticipating that the providers would be calling in, to find that there was very little increase in the call center volume. So I think we need to think about how to make sure that the word is out with providers that, reach out to the plan, because the plan can provide some accommodations and such, but they have to know who to help, right? So I think that was also a lesson learned. But it's also interesting that from a communication standpoint, a lot of press and Hill and others asking the health plan community who's impacted, as opposed to change and providers, which is interesting because from the plan side, it's, I kind of described a little bit as, forensic science. It's a little bit more of a proxy when it comes from the plan, because it's, for example, measures like who's not billing, right? So what are you not getting? It's sort of the null, and sort of things like areas where there are concerns around high potential denial rates of plans having to go kind of hunt for that, versus communication to the plans of here's what the problem is, where it is, what can be done about it. So I think all around, better communication can facilitate us getting to the recovery phase.
Excellent points. Appreciate that. We'll go Pam, Beth, then Stanley. Welcome, Pam.
Thanks, Rob. I just to pile on to what Danielle said about over communicating, I just wanted to share that the communication of alternatives is not it's not a one-time event, because the process was ongoing from a clearinghouse perspective. And speaking on behalf of the cooperative exchange and clearinghouses, the process was ongoing as all the different clearinghouses worked to identify what are alternate paths, what can we bring up, what direct connections can we identify, et cetera. So it actually was an ongoing process to and continually changing for what alternatives were available. So I mean, we as the cooperative exchange provided information to different sources, but having a place where everyone could go to identify what's going on, how can I get my information where I'm trying to get it, would be beneficial, because there were a lot of different people all doing a lot of different activities trying to communicate, but it was very dynamic and ongoing. So communication really needs to be continual, and there needs to be an easy place to go to get that communication. I think that's one of the challenges that we identified here.
Excellent.
Yeah, and I'll just build on that, on Pam's comments that, communication early and often, that's important, but we also have to think, and I don't know the answer for this necessarily, is that, with this situation, you didn't just have kind of one-on-one relationships impacted. You had this spaghetti, and you had sometimes thousands of payer routes impacted. that you are working through and trying to keep all these flavors different because you had to take different approaches, and trying to create or search out what the options were for those thousands of different connections. It became kind of a nightmare to manage. You have these huge spreadsheets with all kinds of designations in there trying to describe all these flavors of things. And it would be good if we didn't have to do as much research to find what the options are. I don't know that necessarily some repository or some central place is maybe I'm not sure what the answer is, but the amount of research that had to be done to find what options did you have here was very challenging at the scale that we had to work in. Thank you.
Excellent points. Stanley, Terry, then Stephen.
Yeah, this goes to I think the preparation. When we talk about contingency plans or disaster recovery plans, a lot of these things that Beth and Pam were talking about, alternatives and such, these should all be decided upon ahead of time or planned ahead of time. Communication vehicles, if there should be a portal or a web page or something ahead of time where providers would know if they hear about a cyber attack or something like that. Here's where you go for your source of truth for Change Healthcare or for SSI or for any place else or for Anthem. Those kinds of things. Being prepared is really critical here. I think part of the issue is nobody really thought that a cyber attack on this scale could happen and impact so many people. So that's really part of this. We've ignored some of this contingency planning. People might have done risk assessments ahead of time, but they haven't taken that second step to be prepared when something happens. Thanks.
Yeah, and I'll just add the third step, Stanley, is that outreach to your trading partners to include them in your contingency planning as well. But great points. We'll go Terry, Stephen, and then Mike.
I think this is along the same lines of what others are saying. Obviously, there's planning and there's some communications of the alternatives. In developing that list of alternatives, I think it can't just be, oh, we've got paper portal. I think you really need to think comprehensively as to the type of claims and what you've got incoming. You know, and again, not pointing fingers on the last one, but we saw plans that were offering, well, we've got paper claims available. And if you think about a large health system or something like that, the submission of paper claims is probably not a practical solution. And so to say that you've got an alternative, well, that's true, that's not really a workable alternative. And so I think as plans build kind of these redundancies, I think it's important to ensure that the redundancies are created in a manner that you can meet the different types of customers that you have for, you know, that might be encountering the difficulties due to the system outage.
Good. Stephen?
Yeah, I'm going to keep the theme going here, and I definitely want to agree with Stanley that continuity planning is critical here. And I think that what we learned out of this, and I certainly appreciate the comments about communication. Communication is important, but the problem is in a situation like this, and you're talking about the just phenomenally complex interconnected nature of the U.S. health system, you're not going to talk your way through that on a conference call, right? That there has to be highly thought out and detailed planning and testing. So that's the part I would add to this, is that there really has to be multi-party testing of these scenarios, right? Because a lot of the things that we came across, you know, to a lot of the things that Terry was talking about, you're not going to realize that if you're, you know, you can plan it all you want in a vacuum as an individual health system, individual payer, even as payers as a group or health systems as a group. But until you start getting multiple groups together and do stress testing type scenarios similar to what financial services does, you're never going to flesh those things out or be adequately prepared for them.
Excellent. And Mike will give you the last word on this.
Yeah, I appreciate that. So just to echo what my colleagues are saying and maybe expand on it a bit, you know, certainly think about what kind of risks you face. You know, think about your key strategic partners. And like what was just said, you know, think about working through, you know, actual recovery plans with them. I know everybody on the call here probably does their own disaster or business continuity recovery, but beginning to expand that scope, beginning to expand that circle, and beginning to talk to your strategic partners to engage them and have them participate is another good way to have a good understanding of where your risks are, where your strategic partners are at risk, and really to flex the network so that you've got a better sense for what gaps you have to fill.
Great points. And we're going to revisit the idea of working with your trading partners a little bit later as well, but very important. Let's go to the next slide. And again, if you have worked on these issues internally, if you've got some ideas that you're willing to share in the chat, that would be extremely helpful as well. So let's talk about some specific things that health plans can do. So for example, relaxing some of the administrative burdens, things like quality reporting, chart audits, things like that. Maybe relaxed edits to allow more direct connections, pausing prior authorizations, pausing requirements on timely billing, things like that. So let's open that up. Mike, I see your hand. I don't know if it was up from before or you want to comment on this. Beth, we'll go to you first.
Okay, thank you. So one of the biggest burdens that I heard about and experienced was the remittance aspect. You might think that claims are the priority because that's where the money comes in, but there's a lot of money held up when it takes a long time to get those remits, when they're suspended or you have to re-enroll and they're telling you 5 weeks to re-enroll. Then what about the gap that you're missing that's been delivered somewhere else? I really think if we could come up with a way to really all the time reduce the burden of remittance enrollment. It seems like I don't know all the things a payer has to do on their side, but it seems as if the clearinghouses could perhaps act as an agent for providers to move those things around and do re-enrollments without so much multiple levels of input from providers, from intermediaries, and so forth. But that holdup of the remittance transaction caused people not to be able to post them. If they got a paper one, it might take them days to post something that electronically takes 30 seconds. They didn't have a staff for that. When they couldn't post those remittances, they couldn't bill for secondary, they couldn't bill balance due, they couldn't collect a lot of money that still held up even today. I would encourage all of us to come together to see, can we shorten that turnaround time, and what are the options for providers to get remits that may have been delivered to another clearinghouse and that clearinghouse is not available or that entity is not available. Thanks.
Excellent points. We'll go Danielle, Pam, then Stanley.
Yeah, certainly remittance advice was something that was raised to us. In fact, Steve, I think on here, is the one who first raised it to the plans in this particular case. And at first there was none, but then the plans at least started doing the paper so that there'd be something, right? So that's part of why I was saying, like, to Terry's point, like, no, you can't do paper claims forever, but there's sort of the really short-term band-aids that are paper claims, paper remits, things like that. And then there's sort of the medium term of like rerouting to a new clearinghouse, and then you get back to the clearinghouse, right? So there's sort of stages, and I think we have to recognize that it evolves as the process goes, and that there is not only going to be one gold standard, because it's going to depend on what's available as you evolve through the process. But there is a role for some of those band-aids at the very beginning. So part of what I would just point out here is that the health plans were impacted in a lot of the same ways that the providers were impacted. So in some of these cases, the plans are actually having the same problem. For quality reporting, as an example, the HEDIS engine was down and chart abstraction was down. So when it comes to making accommodations for the providers, it's one thing for a payer to make accommodations within their own value-based programs, as an example. But if it's something that the payers need from the providers for HEDIS and NCQA is not making any waivers, then we're kind of up against a wall, right? So that's where we have to figure out, I think, probably common ground for joint advocacy to federal agencies and accrediting bodies and et cetera. Because I will say NCQA made very, very tiny accommodations. But others examples were the risk adjustment reporting, just to give another example. The other, I think thing is we need to have the word targeted in front of some of these. Prior authorizations were not down for the vast majority of plans. In our surveys, it was about 13% that were down. And so we can't, there isn't sort of a belief that there just needs to be like, let's turn all prior off, right? It has to be targeted to impacted providers, right? And where it makes sense. And the same thing for timely billing. But the wrinkle with timely billing is that a lot of the timely billing and timely payment, there are state rules that we were also running into, and a lot of states putting out sort of reminders to everybody that there are both timely and clean claims rules, both billing and payment. So I think that's another area where we have to think of sort of broader policy issues. It's not just at the federal level, but at the state level. So I'll stop there.
Yeah, I appreciate that. And we're getting some great comments in the chat. I will say, as a reminder, we capture all of the chat. So as we develop our final recommendations, we will take into account the comments made here. So let's go Pam, then Stanley, and then we'll move to the next slide.
Thanks. And I just wanted to kind of pick up on Beth's comments around the remittance advice that I agree. There's so much focus on making sure we get the claims flowing, but until the remittance flows back the other direction to the provider, they can't update their accounts. They can't get accurate patient statements out. They can't do secondary billing, et cetera. And enrollments is a major burden in that area, trying to get those remittances flowing again. And I'll point out that WEDI just recently published a paper on ERA and EFT enrollments that points out some best practices that if they were in place, really could have helped in this situation. And one of the example of that is allowing bulk enrollment, for example, submitting a spreadsheet or other method to submit enrollments for a large number of NPIs all at one time, rather than having to complete an individual form. Payers allowing an electronic method of enrollment rather than requiring a paper form or wet signature. Things like that, allowing a clearinghouse to act as an agent on behalf of the provider to make those changes for them. There are a lot of best practices that could be put in place that would help facilitate redundancy in some of these situations. And I'll also point out that there is an EDI transaction that does the enrollment for EDI transactions. There's an EDI transaction to do enrollments for EDI transactions, the 838. And if that were in place and being widely used, that could have done enrollments in a much more timely manner and got things flowing more quickly. So I would just like to point out there are some recommendations out there in this paper, the best practices paper, and that we potentially should start looking at, can we implement some of these today to help us going forward to expedite some of these areas where we've identified this is a big challenge. This is the long pole in the tent. We need to address some of these issues.
Yep. Excellent points. Stanley, we'll end this slide with your comment.
Thanks, Rob. A couple of things. It seems like we need to consider the priorities of what needs to be reinstated first. Is it remittance advices and getting the payments flowing, and then claims? And I noticed in the chat, Susan mentioned something about eligibility and other transactions. So that's one thing we want to think about, setting the priorities. But I also want us to consider doing some of this stuff ahead of time. I know it's a very touchy subject, but allowing providers to already have a secondary clearinghouse that they've enrolled in, so that you can easily switch, instead of saying, oh my goodness, there's a cybersecurity event. Let's everybody run to the secondary clearinghouse, which may be overwhelmed. It's again, the preparation that needs to be done ahead of time, so you don't face a situation where you have to rush to enroll with somebody else. Thank you.
Excellent. So we'll go to the next slide, and then I'll give Leslie first crack at the comments. Leslie?
Thanks. I'm not sure where this belongs, Rob. I didn't want to lose. I'm trying to follow in the chat as well and gathering those areas that we think really need to be, starting to morph into considerations that we want to put into our letter. David Delano mentioned that he thought industry requirements for clearinghouses to have multiple connections to each plans to have multiple connections to more than one EDI service needs to be there, et cetera. Similar to what Stanley just said. I don't know if you want to revisit this when we get to clearinghouses, but I want to make sure we spend a little bit of time pushing that road a little bit more. We need to hear more from everybody else to see if that's something we want to go down.
Yeah, great point. I think it also applies to providers. There was a comment in the chat about that the provider might not know the back end process, and so it's incumbent upon the provider to understand how the data flows. If it's going through a billing service to a clearinghouse, they need to know that and build in some of their own contingencies as well. So we've talked about reducing some of the burden. We've bled into a little bit on the clearinghouse side, but let's talk about the money flow in terms of health plans. So we've got, again, these are put as questions. So if you, as a health plan, for example, if you have a concern with one or more of these, please raise it in the chat, or facilitators, please raise your hands. But we talked about claims that are in the current pipeline, trying to expedite payments to make sure that there's money flowing back to the provider. There's been a lot of talk about interim payments. Again, not just from the health plan that was directly impacted by the incident, but potentially other health plans in the business chain as well. To mirror a little bit of what happened during the pandemic, and also potentially establish a prepayment process based on historical claims payment. So if you've had a traditional level of payment in May, then the health plan would continue to issue payments in that amount. Stanley, we'll go to you first here.
Yeah, thanks. And number one, it may be a little difficult to expedite the adjudication of current claims if a health plan has been hit by a cyber attack. It doesn't, they can't do it. If this is if it's something in the middle, perhaps they've gotten some claims. But I think, again, the process for interim payments, it's hard to believe that a health plan not directly impacted could do anything. But certainly health plans that are impacted could talk about that, or a prepayment process. That clearly keeping the money flowing for providers is a critical piece here. And with the understanding that the resolution of these payments may be very difficult, how to resolve the payments once everything starts flowing, but clearly some way to keep providers going and allowing them to continue to see patients and operate is critical. Taking out loans, the additional cost of business may be too much for certain providers, but payments based on historical rates, I think, is probably the way to go. But again, something that ought to be prepared ahead of time.
Great points, and I think you made an excellent point about, you know, the health. If the health plan is hit, it may not be able to adjudicate the claims in its pipeline. I think it would apply more so if one of their trading partners was hit. But yeah, great points. We'll go Pam and then Danielle.
Yeah, I'd like to point out one item that's not on this slide is the recoupment part of this. So yes, establishing a prepayment process, all of these things that are on here, that's great. That keeps the funds flowing initially. Health plans then need to track, okay, here's how much I've paid the provider, here's how much I'm adjudicating their claims for. And then they need to clearly plan or clearly communicate, here's how I'm going to recoup those funds that I've prepaid you or given you a short-term loan for. Because that's an important part of this. Great, I've sent you a bunch of money to keep you going today, but once claims get flowing again, once we start adjudicating again, I'm going to start recouping all that money. And so are you then not going to have any checks because, or any payments, because I'm recouping all the money that I paid you up front? So there needs to be some pre-planning and some communication around the recoupment process as well.
Fantastic points, Pam. I think that's got to be built in. And to Stanley's point, over and over, this has got to be set up ahead of time so everybody knows exactly what the plan is. Danielle?
Yeah, and to tag on to something I said before and something that's in the chat, you know, of the 13% of plans who said they had prior authorization down, all of them said that they were making some sort of accommodations that, you know, didn't happen on day one, right? And perhaps that could have been sooner, but it was in place. In terms of the claims pieces here, I mean, I think there's sort of an order of operations in that, and some of this can only be so pre-wired, right? Recognizing, yes, we should have contingency plans, and the health plans all had contingency plans, and I think actually did a pretty good job at sort of writing their own ship first, and then getting to help it to the point where they could help providers. But there was very commonly getting claims out the door that were already in-house. So in this particular fact pattern, they were able to do so by hiring extra staff, working over the weekend, working nights, etc., clearing the decks. But then it was sort of, how do we get people rerouted, you know, a stabler system away from paper? Some of what we heard from organizations and some of what you've seen in the chat was, well, we have an exclusive arrangement, we're not sure if we are allowed to. We think
Gotcha.
This is going to be really short. It might not be worth it for us, right? Not everybody was willing to reroute. And so that's something I think we need to, I don't have an answer for that quite yet, but I think we need to think through, because that really prolonged and made some of the damage larger and bigger. The notion then of some sort of loan programs, and we're focusing on the plans here, and I'm, you know, going across buckets a little bit, but I think there has to be a role for the organization where the problem occurred. And loans that are sometimes a little bit easier to administer, you pay it, you get it back, it's not really a reconciliation, that can be easier. So
Gotcha.
from the plan's perspective, the advance payments or interim payments, or however exactly you want to structure that, is sort of last resort, because it's so messy and cumbersome and costly for both the providers and the payers on the backside. And then the last thing I'll just say is, actually, we did see some plans making accommodations because who did have claims flowing with providers. You know, because you've got two buckets there, the directly and indirectly. Some of the payers who were able to reestablish connections with providers earlier than others actually then paid out the bolus, the backlog, in 2 to 3 days instead of, you know, 7 to 14 days or whatever, to help particular providers have cash flow. So they expedited, even though they weren't at that point the impacted payer, they were still trying to kind of help the system by getting dollars out there. So there are some things that can be done.
Excellent. Great points. Ed, I think I know what you're going to say.
Yeah, I do have a comment, Rob.
Okay, great.
So, we did cover some of the clearinghouse topic under the health plan, because, certainly that there are key vendors as well as the payment vendors and all that would, move these administrative transactions through. I think maybe if we can spend maybe 5 minutes talking about some of the decision support, the value-based care models that require, the partnership between the provider and the payer. What happens if those systems are down? The HEDIS, I think what Danielle brought up, I thought was a really good call out, which was, other kind of reporting that health plans have to do. It's all their system, right? I mean, gosh, when a ransomware happens, it will hit every single server that they could possibly do and lock it down with an encryption key, right? And they'll steal any data that's not at rest, encrypted at rest. So perhaps we can talk just about 5 minutes about some of the other systems that could be impacted and how you recover, and then move on to the clearinghouse. How about that?
Yeah, so we'll go to the next slide, but I do want to put a marker there per Ed's suggestion, because I know we talk a little bit later in the slide deck about trying to ease the reporting requirements, but cyber attacks are not strictly limited to administrative systems. They also impact clinical, value-based care, clinical trials, all of these things. So I think we can probably skip the slide. I think we talked enough about this, and we also talked about the enrollment. So Mike, I'm going to give you last word on this, and then we'll move to the vendor side.
Sure. I was maybe this is a good segue to the vendor side. I was just responding to some of Ed's comments there. When you think about an attack like a type of ransomware attack, certainly as Ed was saying, it's not just the core system that's attacked. The follow-on effects are, if the vendor, if the organization had their development environment breached, right? So you begin to think about that slows their development, that slows their recovery, that slows changes or integration that they may have been doing. It may impact their billing. It may impact all of their sort of administrative operations behind the scenes. It is obviously very impactful to patients. It's very impactful to providers and the rest of the ecosystem from a financial perspective. But the recovery time, depending on what's impacted by that ransomware, has follow-on effects that may go months or even years down the road.
Excellent points. So let's move to the next slide, Michael, I think, or 2 slides. So we've obviously talked about clearinghouses. So the question on the table is, what steps can clearinghouses take or should take in these areas? So obviously, we've talked a lot about transparency, making sure that I think Danielle made the point of that the communication is 2 ways. It's got to go back and forth. Here it's between the clearinghouse and their partners, whether they be health plans, providers, or both. We've talked a lot in the chat about not requiring exclusivity in contracting. David had suggested that maybe we need to have some sort of rule that prohibits these single sources. If there is an exclusive contract, is there a way to encourage clearinghouses to establish a relationship with other clearinghouses to be able to use them should their own systems go down? I know Pam has spent a lot of time discussing enrollment and trying to find ways to expedite that. And a simple one is to make sure that everybody has everybody's contact information. So if there is an issue, the worst thing is that you don't know who to call. And so it's a very important first step is to identify those emergency contacts. So with that, we'll open it up. Stanley, we'll go to you first, and then Mike.
The first bullet point on constant information and sharing and transparency obviously applies to any entity that's impacted. But there are some considerations. I recall that think there's some information that can't be shared during an attack. You might not necessarily want to share items about who attacked you or what the attack was all about. You can think about the services, what's down, and when services are expected to resume. But there are some things that in any sort of criminal investigation cannot be shared. So we have to be careful of that. But again, being public with systems and when services are expected to resume, I think is really critical. Those decision points on when services are going to resume are going to drive a lot of decisions.
Excellent points. Mike and then Beth.
Yeah, I would agree with Stanley. Transparency is absolutely key, and not just during some type of cyber attack, but services go up and down on a regular basis. Your clearinghouse may not be able to service you because a payer system may be down, right? So one of their APIs may be down, and you can't connect to that payer through the clearinghouse. A couple of other thoughts here that sort of rolling in the back of my mind is making sure that your clearinghouse or clearinghouses have some basic standards in place, like a SOC 2 with all 5 trust service criteria, right? Making sure that they have a relevant high trust, making sure that they're following something like ENAC and have certification from ENAC. I think setting those bars and requiring those bars out of your clearinghouses is incredibly important. And then, to the point about emergency contacts, I think it's even beyond emergency contacts. It said this a little bit earlier. I think it's important to, at least on an annual basis, to sit down with your strategic partners, and a clearinghouse would be a strategic partner, and say, what is your recovery plan? What are you actually doing to be ready? And to walk through it with them and have not just a list of contacts, but have a good understanding of what kind of steps they're going to follow in the event of some type of catastrophic outage, either a cybersecurity event or, like what was said earlier, some kind of natural disaster.
Great points. Before we go to Beth, I'm going to maybe call on Leslie because Mike raises an issue. Should the accreditation programs should they be required on these entities? And then second, should the accreditation programs include a broader set of requirements like we've been discussing here? So contingency planning for external, not just internal, and disaster recovery.
Yeah, actually, I was going to add that before you decided to call on me, Rob, and I've obviously been taking a lot of notes as well. There was a long period of time that you saw the industry, when we implemented HIPAA, et cetera, be concerned about other business partners, et cetera. But over the last few years, we've seen a huge push to make sure that there's vendor due diligence. Everybody who's subject to HIPAA should be doing due diligence on all of their business partners. So it makes great sense. Just like we now expect to see due diligence and ongoing performance review, reviews of SLAs and other things on key partners, that it also include more of a push into some sort of coordinated effort for this testing of negative incidents, negative events. So that's exactly where I was thinking as well, that adding that to accreditation and certification is one way to push this out and really raise the bar across all the organizations without making one responsible for another,
Yep. Yeah. I appreciate that. And Mike, thank you for bringing that up. Sorry, but we'll go Beth, then Terry, and then Pam.
All right, thank you. So I mean, there is the way some of the business models work between these organizations don't necessarily lend themselves to this type of situation. Now, when you're in a crisis like this, those barriers do come down and people will talk about it. But in general, there's a reluctance to share exclusive contracts because there's reluctance to share those types of information outside of a crisis because it gives competitive advantage. And, you know, I don't know how we solve for that. It's just been a fact. And maybe things like this help tear those down. But I also have to wonder too, you know, we have all these accreditations, and most of us who are doing business have those. We have the audits, we do all those things. And, you know, my question is, we don't really know, you know, the details of how this particular event managed to still have the effects it did in spite of these accreditations that were already attested to. So without knowing that, it's difficult to say, well, what do you put in place that would mitigate for these things that happen, because we don't have the details to examine that. And lastly, I'll just raise that. Oh gosh, it went right out of my head. That there, you know, we're kind of you know, saying all the things that went wrong, but I really have to say that all the organizations I work with, and I work with a whole bunch of them, clearinghouses, payers, etc. Everybody was all in to help our providers, to help each other. And those walls were down for a while, and they still are, while we work through a lot of these things. But there's some things that we just, it's almost like a disclaimer or something, that you don't talk about certain things because it's business, or, and I can't remember the terms going right out of my head. But, you know, how do you, it is a business at the end of the day. How do you protect some of those interests and provide redundancy? I think a lot of it comes in is like they were saying in the chat, resilience and redundancies. It's like, okay, well, if you narrow your worldview so tiny that you just have one person, that might be good for your organization because you only have to work with one other organization to but you're also putting your providers at risk because you've blocked access through other methods. And it doesn't have to be there all the time. You just need to have a way to go around that for all the transactions with the shortest amount of time.
Excellent. I appreciate that. We'll go Terry, and then Pam, and then Danielle, and then we'll move on to the next slide.
Sure. One thing that's not on the slide, and I think it was expressed earlier, but I want to make sure it's expressed in the clearinghouse space, is there needs to be testing to ensure that a clearinghouse can like absorb additional bandwidth, or you're going to develop these solutions and try to have all hands on deck. I think it would be helpful to know, you know, if you're going to be for clearinghouses to understand what capacity can they help, can their systems handle, et cetera, just because obviously in the past, a large clearinghouse such as change going on, it's great to see the desire in this kind of all hands on deck, let's help the community. But there was always this concern, do we know that these clearinghouses are going to be sufficiently prepared to take on the influx of a whole bunch of additional claims, et cetera? And so I think testing and being sure that there is the capability of taking on, of absorbing the additional transactional load would be helpful in this space.
Yeah, and I think that gets to a broader issue. Again, we go back to making sure you're doing this testing before an incident happens. So then the clearinghouse can say, I can accept X amount, and after that, we're going to have to route you over to someone else. I think that's a great point, Terry. So we'll go Pam, Danielle, and then we'll move on to the next slide.
Thanks, Rob. I just wanted to point out, and I'll encourage Sherry to jump in the chat as well, but clearinghouses obviously do go through this certification process, and there are multiple certifications that have to take place. So there's ENAC, there's High Trust, there's SOC, et cetera. There's a multitude of different certification entities that clearinghouses can choose to get, not choose to get, choose to get all of them. There's a lot of overlap between them, and each one of them is very expensive to get. So it's challenging to go through the certification process, but obviously a necessary act to take place to ensure the security of what we're trying to do, not just for clearinghouses, but for any entity. So one thing that we might want to look at or recommend is how can that be consolidated? How can we reduce the burden of certification so that there's not so much overlap, there's not multiple entities that everybody needs to certify with, and it's not so financially burdensome as well, because again, these certifications are individually can be very expensive. And again, there's a lot of overlap between them where there can be. So, and I think I saw it pointed out in the chat, the certifications don't always, they're a point in time, and they don't always cover everything that needs to be covered. Obviously, you can have certification and still incur a breach. So this might be one area that needs some attention. How can we consolidate that and potentially get more breadth within what the certification is taking a look at?
Excellent points, Pam. Danielle, you get the last word on clearinghouses.
Yeah, I think the specific thing is also, one aspect that's been particularly problematic is, most organizations if they have cyber insurance, et cetera, require third-party attestations to basically show you that it's safe to reconnect. That's been sort of hard going, making sure that those are in place. So I think that's a best practice we should acknowledge, and perhaps even a requirement, not just a best practice. And then just on what Beth was saying, the antitrust concerns are real within this type of situation. There are some exceptions around information sharing for cyber, but we don't think they're anywhere near broad enough. So I will say 95% of our communications with our plans has been a plan by plan by plan calling rather than any sort of joint convening. So any sort of government sponsored or, safe place to have some of the conversations that include business processes, because right now you're not supposed to talk about that. It's really only about the threat itself, is something we need to figure out.
Excellent. So let's go to the next slide. And I'm so happy that we have Sherry on the line to talk about this. This is that critical link between the provider and the health plan, and that is the EHR/practice management system software. So our thoughts are, working with our clients to develop a contingency plans, developing these workarounds, conducting regular system testing, including recovery using backups, and again, to identify emergency contacts. So whether it be payers, other providers. So if a provider system goes down, they may need to send patients up the street to another clinic. And then the question is, what other things can we ask of our vendor partners here? So maybe Sherry, I'll start with you.
Sure, Rob, happy to help. Again, wearing both my EHRA hat and NextGen, we took a poll and obviously every member of EHRA was impacted by this in some way. For those that may not understand, it's often the HR vendor with their practice management system at the time of either purchase or implementation that the provider group makes a decision regarding how they want to handle the clearinghouse. They either already have a clearinghouse that we need to coordinate with, or they'll choose a selected vendor. Now, one of the things that we've recommended and that we do at NextGen is we're not single threaded. We have multiple options for multiple different kinds of scenarios for our clients. And in this particular situation, although we were not a direct partner with Change, the interdependencies and especially the exclusivity for specific payers actually directly impacted our clients. So obviously, SWAT teams were set up, 24/7 communication was set up. Communication was absolutely key. There was so much misinformation and so much concern and confusion about what's going on. So obviously most of the vendors provided FAQs and kind of daily post updates to their various CRM systems or whatever to let people know just what was happening. I will say that the coordination with both Optum and Change, and to a certain degree United, was critical. And, they set up these routine daily calls that allowed everyone to exchange information and to provide updates. The other incident that happened, though, the providers were going to Congress, they were going to their various medical societies. The AMA directly reached out to the vendor community asking for any help we could provide in financial forgiveness and in financial support, as well as coordination with the payers regarding trying to get these practices back up online, because many of them were in truly desperate states, could not make payroll and could not see patients. And yet, even when they took some of the loans, they were concerned about spending the money because there wasn't clear direction or communication on what the payback program would be and how they needed to handle it. And I think Danielle or someone talked about the whole remittance problem. So all of this created kind of a new scenario that certainly has never happened before. We did have clients that elected to change clearinghouses as a result. And then we also worked with the process where Change, through their own clearinghouse, converted everyone over to the IEDI, which was the Optum clearinghouse. So that was a process in and of itself that we had to coordinate if we had connections there. We're being asked on follow-up for what are the compliance plans for the actual EHR vendors themselves, which is forcing us to take a look at, all of our security protocols. And not only do we look at those partners that we make, what their security requirements are, and like someone said, are they doing high trust? Are they doing SOC 2, whatever? But how do we look at contingency and compliance plans, and obviously lessons learned from all of this to make this more efficient? And then lastly, many of you on this call I know are also participating, including WEDI. EHRA does as well with the HSCC. And Greg Garcia obviously testified before Congress around very specific best practices and recommendations that the cyber community as a whole looked at, regarding this incident, and, definitely are, basically saying and making recommendations. I mean, this is a game-changing event for healthcare as a whole, and something that was a real wake-up call, I think, for all of us.
Yeah, great point, Sherry. Thank you so much. And I think, if there is an overall message here, it's this is a wake-up call. I think Ed said it at the beginning. This is likely not to be the last cyber incident healthcare is going to face. We'll go.
And I'll also say, I mean, yes, there are a number of things that have been improved, but this is still ongoing. I got a debrief from my EDI resource before this call, and she told me what's working, what's not working, but things are not back to normal or 100% by any means. And yep. We're, close to 3 months into the event.
Yep. Great point. We'll go Stanley, then Tian Tang, and then Stephen.
Right. It's kind of a shame that we needed this wake-up event. Cybersecurity and breaches have been around for quite a while, certainly in other industries and even in the healthcare industry. But this one was, I guess, a lot more wide-reaching. I think the vendors have a unique place here in that providers, plans, and others do tend to rely a lot on their vendors to take care of this type of effort. A lot of providers say, look, that's why I hire you guys. You do it for me. So, in preparation, I guess this is a two-way street. If the vendors want to volunteer to be the security police or whatever for their, or the contingency plan for their customers, that would be great. And, they can build that into contracts and such. It might be something that we make providers and others a little bit more aware of. We've had the same discussion anytime there's a standards update, that providers rely on vendors, plans rely on vendors. So the same thing could be said for security. There needs to be a determination of exactly the role that vendors should play and what should be part of their contracts.
Good point, Johnny. Tantian, then Stephen, Beth, then Mike.
Yeah, thanks. Thank you, Rob. And I do want to echo what Stanley said in terms of the critical importance of the vendor in this space here. I mean, there isn't an entity out there that's operating without relying on a vendor for something, whether that's human resource, software, or infrastructure support. So my point is a little bit more high level in terms of, and not just specific to the Change Healthcare event that just occurred, in that the reliance on the vendor, it's not just a software vendor, because nowadays we're facing a situation where we have cloud support, and that cloud service provider could be giving you both the software, the infrastructure support, and the hosting. So, you've got all your babies in one basket there. And that one vendor, you're not just working with one vendor, but you're working with multiple vendors. So the organization needs to think, if I'm doing my continuity planning, it is working with a whole host of different vendors and to build your continuity plan. And so it means your testing has to involve all of those entities, all your critical vendors together. It's not doing testing with just one by one, because it's a fail safe. You've got the weakest chain in the link fail, everyone fail.
No, good. And we're going to be discussing that exact issue a little bit later when we talk about, do we need to have sort of a time frame for everyone to start their testing? So I think it's critical. Thank you. We'll do quick. We're going to Stephen, Beth, Mike, and then we're going to move quickly over to the provider side.
Yeah, I mean, since we're getting over to the provider side, we'll talk about some of the provider perspective on that. I just want to touch on some of the things that Shuri talked about, specifically around EHRs. If you thought it took a long time to switch clearinghouses, it would take 18 months to switch an EHR, right? So we've already started. The AHA has already reached out to Epic, and we're going to be talking to, having the same conversation with Oracle and Meditech. That, let's face it, and let's talk about the wake-up call. You have a nation-state actor that has a better understanding of the interconnectedness of the United States healthcare system than our policymakers do, period, and stop. So if they knew and were smart enough, and let's assume they were, to attack the clearinghouse system, they're going to be smart enough to understand that you have software that is, really 3 software companies that are responsible for 80% of the beds in for all health systems, right? So we really have to think about what is the next big target. We know they're out there, and we have to be talking really openly as groups as to what those impacts are going to be. And one of the things that Tantan had talked about, the other technology pieces, the cloud services pieces, right? It's not just the EHRs. I mean, let's face it, 90% of the world runs on a Microsoft operating system, right? And Microsoft has actually demonstrated some fairly serious security flaws, which I know Mike would attest to. So these are, and this is a critical infrastructure of an organization that will not sign a BAA and does not operate as a covered entity, does not operate under the same rules as any of us on this call. That has to be considered, right? And I guess the last point here is we talk about some of the changes that we're going to be making, and someone point out some of, Greg Garcia's comments, and we certainly appreciate, we work with the HSCC, but I would caution that we would start adding new regulations before we all look back and say, hey, we've got 42 regulations of critical infrastructure safeguards that are already in HIPAA. We already have a very well-defined piece of regulation that's out there. I would just encourage that as you all hear these conversations, pause the conversation and say, that's great. Let's consider the existing framework we already have. Because, adding an additional regulatory framework on top of a regulatory framework that's not fully utilized is not going to be a solution to this problem.
Great comments. So very quick, Beth, then Mike, and then we're going to be moving to the provider side.
Sure, I'll make mine very quick. So just a reminder that all service is not yet restored. We're still in this. And one thing that I did find kind of disappointing was, our security experts advised us based on updates, how long they thought this would last, and what types of things that they were probably dealing with, so that we could make decisions in the moment on how much work and resources to invest on certain things and what should be waiting on. Because honestly, when this first started happening, there was so much to do. You absolutely absolutely had to prioritize the most important first. That was restoring your claim connections, restoring eligibility, those types of things, and working around. Then remittance kind of came next. And what we found was that, first of all, because we didn't have any kind of overarching plan, it was very far into it before we even had any word that we were going to be down for several weeks as opposed to just a week or so. And so we were constantly changing our strategy, even though we really did start out knowing that it was going to be longer term. But we made decisions to wait on re-enrollment because it's so long that then people got in a fix kind of with remit, but we really didn't have the bandwidth to divide and conquer over there either. So it was a matter kind of what you could work on at any given time because there was so much going on. But it was disappointing to get as far as we did into it to find that some business decisions were made not to reopen parts of the connectivity back to the way it was. And I don't know why some of those decisions were made, but it did leave us scrambling very late in the game, having prioritized some of those things lower, not knowing that okay, now we're on the way back up, but these we're going to move over to this other site, and that's going to be a few more months, and we can't really tell you when these payers are going to come online. And it just really had a big delaying and disappointing effect that wasn't kind of planned for or announced much earlier in the process.
Yep. No, good point. Mike, you got the last word here.
Sure. I'll just echo a couple of other folks' statements and maybe try and drive it home. Have a plan, right? Have a risk management plan. As we were just hearing Beth say, someone's telling them, hey, we'll probably be up tomorrow, maybe the next day. I'm not really sure. Day after that, don't worry about it. Have a hard plan where you say, like, if they're down 5 days, we go do something else, right? We have to protect our business. We have to protect providers. And have that for all, again, have that for all of your strategic vendors. If you can't do without this vendor, if your business can't operate without this vendor, you need to have those hard conversations with them. The other, and to Stephen's point, there are a ton of regulations out there already right now. Part of this is in the industry, we have just not pushed people to say, what are you actually doing? How are you actually following these regulations? The suggestion I would have here in dealing with your software vendors, make sure you're including your IT team, right? Make sure you're including your internal security team in those conversations with those vendors so they can really drive those conversations and say, all right, you provided me with a SOC 2, but it's not for the product I'm purchasing. It's for another product in your organization. It's great that you have that for that product, but it doesn't actually cover the scope of what I'm buying here. So that you can have more sophisticated conversations using the frameworks that we already have in place to drive out those operators in this space that are falling below the bar and are creating more risk for the rest of us in this ecosystem.
Excellent. And my big takeaway there is maybe it's a question for each of the trading partners to say, if you're not back up in 5 days, what is your contingency plan, and have that in writing ahead of time. I think that's one of the points that I'm hearing here. Great. So let's move to the next slide. We've already started to talk about what providers can do. So we're going to talk about ensuring cash flow, because obviously this incident has put a very bright light on some of the challenges, in particular, that at smaller hospitals, smaller physician practices have faced. So let's talk about some of the things that providers can do. We've talked about that transparency, reaching out to their trading partners, and one of the things, a lot of the smaller, in particular, smaller physician practices, dental offices, folks like that, they don't have IT staff. So they outsource that to either a firm or a consultant. And how do they at least have some questions that they can pose to these individuals or firms, right? To have okay, what if this happens? What are my options? So get that conversation started. And then we talked a lot about making sure that the lines of communication are open, that you know who to contact, whether it be a person or an office. Next slide. And again, we talked about having contingencies in place. So maybe I'll ask Stephen and Terry about hospital planning. And I know just to put a plug in for our spring conference, we are going to have a hospital that was hit, or a medical center that was hit by a ransomware attack, talking on our first day. So we'll find out a little bit about what they did. But what are your thoughts in terms of hospitals identifying alternative pathways for data exchange?
Yeah, so I mean, obviously, this is something that I think has been, the recent cyber attack's been a bit of a wake-up call in terms of building in redundancies in your operations, and identifying, do you have redundancy so you can have this, if one system goes down, you're not leaving yourself high and dry, having to rely on something like a paper billing. And so trying to avoid anything like that happening is certainly something that is now on everyone's radar, to try to build in that type of contingency. At least, yeah, in the operational space. I don't know. Hospitals are I think it might be interesting to hear, at least in the cybersecurity space, from like more providers. The one, I don't want to say, the one good piece for hospitals is, at least hospitals did have a certain element of cybersecurity requirements, and they were familiar. And I think this might have even been more catching a provider community that might not have had to meet some of the rigorous cybersecurity requirements that are in place for hospitals, as like a physician's office. And so I think just getting everyone onto that same page of building in contingencies, and then building in whatever necessary cybersecurity means need to be taking place. And obviously, I invite Stephen to add anything to what I said, because when I start talking about cybersecurity, I get a little bit of twitch in my face. I'm not really sure exactly the specifics.
You did a good job of teeing it up, Terry. So I think, one, just to start with the data exchange piece of it. I mean, Terry and I have been on calls with our members, and we've told them point blank, you need to have more than one clearinghouse, right? So now, listening to a lot of the conversations that are leading up to this point, we know there's challenges to make that happen. So where we would turn that, I guess, back to everyone else is, how do we make that happen, right? Whether it's questions about exclusivity agreements or ease of setting up those arrangements. But we feel very strongly that they should not be, that our members should not be in a position where they're dealing with a single clearinghouse, right? They should have alternatives there. And we know there's complications around that, but that is something that we have to consider. Because to get to the next point of it, yeah, paper works until it doesn't. And we're usually talking about paper works for a couple of hours, right? I think that one thing we all have to understand is, this is 2024. This isn't 1997. We can't deliver care efficiently at a level that American society of 2024 expects without technology. It is interconnected. It is part of the fabric of how we deliver care, right? And to think of it as an appendage like we used to, pre-meaningful use days is a mistake. So I think that there's a certain amount that hospitals look at and talk about in terms of what they can do for short-term contingency. And I think this actually came up in one of the chat, conversations, and I appreciate that comment, was people have to think about, these are, events that occur for months. Downtime systems are not going to carry you for months, right? They're just not. So we have to think differently about how that works. And it's, and probably drastically, right? There is investment. And to get back to the point that I've seen some of the comments about, regulations that are just going to cost us more. Agreed. I'd rather spend more money on talking about a more resilient, interconnected system with all of our partners here, everyone who's a covered entity working together and making those investments in resiliency, as opposed to, glorified box checking exercises because we add some new regulation on top, which by the way, is not going to stop the problem, right? If you're talking again about very sophisticated cyber attacks and the environment has changed, the neighborhood has changed, focusing on individual entities, even huge entities like Change, is not going to solve the problem. You know, an organization like Change, which was part of United, which is the fifth largest company in the United States and the largest healthcare company in the world with all its resources, could not stop a willing cyber attacker who's, you know, backed by a, you know, by a nation state. That's the environment we live in, and that's what we have to be thinking about, which, by the way, all of us in our respects that have the ability to then send that message back to lawmakers is you put pressure on them to be our partners here too, right? You know, the American government and the federal government is as responsible as all we are to delivering care and taking care of our patients. And that, in this case, what we need from them is maybe go on the offensive. You know, treat this as if we're in a cyber war situation, taking care of individual, you know, either health systems, payers, or clearinghouses, like you're talking about a local crime situation, is just not effective.
Excellent points. We'll go Pam, then Stanley.
Yeah, I just wanted to talk a little bit about the having multiple clearinghouses discussion, because there's some complexity there. From a claims perspective, you could theoretically, I guess, have multiple clearinghouses. I think the issue is sending the same transaction to multiple clearinghouses or receiving the same transaction from multiple clearinghouses. That doesn't work. And from a remit perspective or a payment perspective, you can't do that. You don't want to get the same remit from multiple places, that kind of thing. But you can, from a provider perspective, you can have multiple clearinghouses that you send different transactions to and from. So that gives you different avenues or different options. If something happens to one of your clearinghouses, it makes it a little bit easier to pivot and send the transactions that were previously going to and from the first clearinghouse to the second one, because you already had that connectivity established with the second one. But there may still be some enrollments required if you were receiving remittances from clearinghouse 1 and you need to pivot to clearinghouse 2. There still are probably going to be enrollments required for that. But it does increase the complexity from a provider perspective, because when you're trying to research, I'm missing a remit, for example. Well, which clearinghouse do I get that from? I get that one from clearinghouse 1. Now I get this one from clearinghouse 2. So figuring out where to go to research issues becomes more complex, but it does give you at least a start towards some redundancy. But again, I think when we're talking about multiple clearinghouses, we have to keep in mind that it can't be for the same transactions to multiple places, because that doesn't work.
Yeah, great points, Pam. And really, it seems to me there's two options here. One is to have essentially contracts with two clearinghouses and sending various transactions to both. The other option is to have two enrollments, but only use one clearinghouse, and then be able to switch over to a second should the need arise. So you're already enrolled, you don't need to go through that process. I don't know, Pam, did I capture that?
The multiple enrollments usually is not, at least from a remittance perspective, that's usually not allowed.
They
Health
can't
plans,
coexist.
yeah, health plans don't allow you to have enrollments for remittances that go to multiple clearinghouses. You have to pick one. So there's just a single path for the remit, and I believe the same is for claims as well, but I'm more familiar with the remit side, and definitely for the payment. You don't want to have the multiple places where your payment might go. But from a remit perspective, you pretty much can have one and it goes one to one place. So it's not like you can have a backup enrollment at the payer that, if I call you and tell you, then switch to this other one, it's a whole new enrollment that's required. So that's a challenge there, that we discussed earlier around the enrollment process. But having some transactions go through clearinghouse 1 and other transactions go through clearinghouse 2, as I mentioned, at least gives you the start at some redundancy if you have to pivot due to an issue.
Go ahead, Stanley.
Oh, sorry, I was waiting for Rob to say, go ahead. I think one of the issues of these, whether we have new regulations or not, is that cybersecurity is an evolving issue. So even though you've met the regulations and you have a contingency plan or you have something in place, you've got to remember that it has to be updated on a periodic basis. The question is, where can anyone go for a gold standard or some sort of standard so that they know that they're up to date and protected against the latest attacks? We have our software vendors are constantly sending out security patches. That's on the software, but there are other things that are going on where not only providers, but everyone needs to update. So I think we've got an issue there. Perhaps when we talk about the role of the government or a partnership between the government and the industry, we've got that as an opportunity. What's the ideal for a cybersecurity program? The other thing that we haven't really talked about is what are other industries doing? I know we consider ourselves unique, but the financial industry, the electronic utility industry, the shipping industry, these are other industries that have been subject to or are having threats of cyber attacks, and perhaps we need to do a better job of partnering with some of these other industries and learning from them. Again, a potential role that the government can help us with, but we really need to step up and say we want to do this as an industry, when we don't want to wait for the government to tell us to do it. We want to recognize that it's a threat. We need to do it ourselves. Thanks.
Yeah, excellent, Stanley. We'll go Mike, then Terry.
Yeah, just a thought on the having multiple sources, right? So clearinghouse or whatever. When we're kind of thinking about that, remember that as much as it, from a business perspective, it feels like a good pathway. In the cybersecurity space, when you set up these multiple connections, you now have to manage those connections. There is a technological element to this. There's some technological overhead, including you now have to manage and secure an additional or multiple connections with another partner. So you're going to have to rotate all those passwords. You're going to have to rotate all those certificates. Your IT team needs to be aware of any vulnerabilities in this new vendor and be able to block and manage those. And if you don't, rather than solving the risk, you've just added a new path for risk or a new vulnerability into your ecosystem. So it really is a balance between all these different types of risk, either the business risk, the technology risk, or how they integrate with each other. I would caution folks to really kind of think about, how do you balance either working with, a vendor or a couple of vendors versus, sort of opening that pathway up and then introducing a whole other set of risks that maybe you haven't thought about or not managing for.
Yeah, I was just going to make the point, as we're talking about having two clearinghouses. I agree that, today there is a problem. You can't send a transaction multiple places. And I think Janice said it in the chat. I think the idea is that you could potentially flip one on when the other is not on. I recognize that there's some concerns and issues with that. You'd have to maintain a connection. You'd also have to pay for some sort of connection. I think that is something that we can start I think a recommendation that it be explored or something like that is how you do that, right? So maybe the contracting of this type of situation has to be different in terms of, I'm not speaking about specifics, but I'm just saying maybe your connection is more of with your supplementary or your secondary clearinghouse is more of a strictly transactional load basis with a smaller, amount. I don't know what that looks like. My point being is, we should update what we can do to the extent that we can be better prepared from what we now know. I know today we don't do this traditionally, but is there a way to do it so that we don't repeat the mistakes we just had in terms of, not being left without a path to get remittances or claims to the proper places? And I don't know the answers to that. And there's folks on this call are so much more familiar and involved in the clearinghouse space. But I think steps should be taken to explore not how does that fit in with what we do today, but how do we make what we do fit with the new reality based on what we've learned?
Yeah, I think that's one of the messages we're learning here. Michael, if we can go to the next slide.
You know, Rob, just in terms of this, I mean, it's interesting. I haven't heard a response back from this incident saying we're going too fast in automating everything or turning everything or putting everything over the internet. We need to slow down until we can protect this better. And it was interesting that I hadn't heard that, but you know, clinical operations are so important that almost more important than the administrative options, because care needs to continue. And you almost wonder if providers should be looking at keeping some sort of a paper backup somehow, so that in the event of a cyber incident, they can continue care. I know how difficult that sounds. I'm sort of throwing that out as an interesting but not necessarily practical idea. But we've got to be able to continue healthcare in when there is a cyber attack, and I'd be interested to hear what people think about that, keeping some sort of a paper process going so it's easier to fall back on that when there is a cyber attack.
Yeah, it's so important, and we did hear from the University of Vermont Medical Center that the more senior physicians had to teach the younger ones how to chart on paper because they'd never done it before. So I think, Stanley, to your point, having some exercises, contingencies, assuming their EHR goes down, here's what we're going to do. And what we found from that case was they couldn't even use their phones because they were internet-based phones. So it's amazing the impact that a cyber incident can have on a hospital. We'll go Stephen, and then we'll move to our next section. Well, I think you're on mute.
Thanks.
Yeah.
I want to follow up on the Vermont situation and just the general idea of paper. So Dr. Loeffler had actually testified, and we had talked to him extensively about this. The University of Vermont's costs in labor hours to maintain normal operations was 68 million in unplanned costs for that time. That would bankrupt many hospitals. I mean, they were lucky, that they were able to work through that. Let's also remember too, when we think about labor intensive practices, right? Like, let's go back to COVID. We survived COVID by throwing bodies at the problem, and we lost 25% of our staffing we will never get back in the healthcare industry, in hospitals, right? We basically worked people way past their ability to do normal work, because we were, of a situation we were unprepared for. Similar is going to happen in the technology space. So I think that I get it, and the idea of paper, I don't want to dismiss paper outright, but what I would say is there's a bridging piece that we have to consider. So we're going to consider contingencies. There are other technology offline contingencies, which again still have limits, but at least you're talking about bridging the gap between, offline PCs, Epic's BCA type devices. God forbid, I know Michael probably roll his eyes at this, the concept of bringing some systems back in-house. Everything's all cloud. I mean, do you keep a limited amount of server space, on site? Crazier ideas are out there, right? But at least I think it's important that we have those conversations and understand there's no easy fix to it. And I mean, the toothpaste is out of the tube. We cannot go back to paper for any extended period, but there are at least, Stanley, I do appreciate that we have to talk through. There has to be some solutions, because I think, again, the point has been made, over and over again throughout this call. It's like the threats are getting worse and more complex. The technology is more interconnected and complex. So we have to think about ways to manage reasonably over longer periods and longer duration and more severe outages.
Perfect. Okay, we're going to move to our next section. And again, we've talked. We can go ahead, Michael. Yeah, go to the next section. And one more. There we go. So we've sort of talked through a lot of this already, but we came up with a list of options really that would impact all stakeholders. And I remember seeing in the Sherry mentioned cyber insurance, and that's probably something most, if not all, organizations should consider. But the one thing that I'm hearing from our facilitators and in the chat is we can't do these things on the fly. Stephen, to your point that you just made, you can't decide after an attack has happened, oh, now we'll try to develop a contingency plan. This has got to be done in advance. And especially if you don't want to go to paper, right? If you want to have a standalone, server-based approach, it's got to be set up well in advance and tested. Anything on this page, any of these bullets that anybody wanted to make a comment on? I see Rebecca. Yeah, they absolutely resorted to paper. But at a minimum, it's good to test that, even as a small provider office, to test your ability to move to paper. And then once you've gone to paper, at some point, you're going to have to transfer that information back into the EHR once it's up and running. We'll go Stanley, then Leslie.
It's a bit of a self-serving remark, and I apologize, but it's fascinating that the HIPAA security rule developed heaven knows how many years ago in the 1990s basically said, this is what you have to do. They talk about the risk assessment being, and the business impact analysis being the core of a security program, and testing and updating that. So it's not implementing cybersecurity controls, technical, physical, and administrative. I mean, this is not new in terms of the steps that need to be taken. I think the issue here is that the industry technology has evolved quite a bit. The dependency on others has evolved quite a bit, and we just need to take a little bit of a fresh look at this and help people develop the right risk assessments and responses to these potential plans. And I'm hoping that's what we can sort of come up with as a new guide to the industry for this.
Leslie?
And I totally agree, Stanley, and would probably, if we had more time, go in a great more detail on just what you said and picking it up and looking at this list. I wanted to call out something that I'm starting to see a lot more. It used to be that when I would ask an organization, we might be assessing, let me see a sample of your incident response plan. I get a very generic one, kind of this works for everything. I am now starting to see, here's my incident response playbook for ransomware. Here's my incident response playbook for some other type. I'm seeing 5, 6, 7 different types of of issues related to the incident that's expected. I just wanted to share that because I think that's kind of a best practice, maybe something we could recommend.
Excellent. Mike, real quick, and then we're going to move to our next section.
Yeah, if we could go back to the slide just really quickly. While I agree with Stanley, like these are all things that are sort of basic, the reality is, and to Leslie's point, I don't think most companies, could lay their hands on all of these items. Yes, they are basic, but how many hospitals could lay their hands on these items in the hospital? How many of your vendors could lay their hands on these items? As basic as they are, I think requiring people to produce this content is a great way to shake out participants in this ecosystem that may be a risk to the larger ecosystem.
Well, and Michael, I would argue that it used to be you as a healthcare organization, you saw this list and the one word that came to mind was compliance. And I think we need to change that paradigm from compliance to business continuity. So don't do this just to avoid an OCR fine.
Agreed.
I think is the
you need to practice this, right? This needs to be a part of your business. You need to practice this. Just like you do any other portion of your business, this needs to be a common practice. You need to be aware of it. Again, that's why I said you can't lay your hands on it. It's probably someplace, but do you know where it is, right? Is it something you put on a shelf, or is it something you're really familiar with?
Exactly. And as Stanley alluded to, this security rule went into effect in 2005. That's a long time ago. And if it's dusted off now, I think it would look a lot different. So I think we can go to the next slide. Very briefly, we've spent a lot of time on this about making sure that there's communication lines, that there's that back and forth. Danielle had mentioned that, to make sure that you're talking to your trading partners ahead of time to say, what are your plans if, and what are our plans if? I think that makes the most sense. So let's go to the next slide. I think we can skip over. Yeah, we can skip this one. We talked about that a little bit. And then the external, yeah, we talked about that a little bit. And we're going to get into that, the idea of working together on what I call a fire drill a little bit later. But let's talk about what we can ask HHS to do. We've talked about, do we need more regulations? Probably not. We have plenty, but there are steps that the federal government can take to help when we've had certainly this type of cyber attack that is so invasive in the industry. I'll start with Lastly and then go with Danielle.
Just very quickly, and it's sort of related, I meant to share it. An organization I've worked with in the state of Indiana has been working with the FBI proactively doing tabletop joint exercises in a city. And I just thought that was a phenomenal example of how you see multiple areas working together, carrying out testing. So it's sort of like this. You've often mentioned, cybersecurity testing week. It kind of fits right in there, Rob.
Perfect. I appreciate that. We'll go Danielle and then Terry.
Yeah, part of what we were thinking, because, to that point of you can't know all of the scenarios in advance and know exactly what needs to be waived. So, now the agencies like CMS have waiver authority that are tied to a national disaster of some sort and, public health emergency, et cetera. But, could there be a corollary for cyber events where you're not naming the specific things you're waiving, but giving them some authority? Because, like the providers are going to immediately come up with these. We want to get paid ones, but the payers on the other side are, concerned about what is this going to do to our risk adjustment? What is this going to do to our HEDIS benchmarks? What is this going to, any sort of quality benchmarks, et cetera. So I don't know that we can be like super prescriptive about that. The other couple of things is definitely the antitrust thing that I mentioned before and some sort of additional leeway there. We found the communication from the government to be very lacking, and a little bit CMS, but not so much, but more of the, cyber and law enforcement agencies, and not having sort of that information kind of like in one place at one time. Like we were saying, the payers should do for the providers. We also felt like the government wasn't really doing that for us. And the sort of other bucket is OCR reporting, and whether or not there's, some streamlining that can be done when it's, something that's this big.
Excellent point. Terry, I don't know if you wanted to make a point.
Yeah, Danielle already said one of the main things I was going to say, which is creating some sort of a corollary to the idea of like a public health emergency that can be enacted. particularly in the space of Medicare and Medicaid giving financial assistance. Right now, the program that they have comes with a Treasury set interest rate, which I think is 13%. That was not something that was present during the pandemic because of the public health emergency, I think, and other things along those lines. And I think that kind of significant interest rate that was associated with the inability to kind of issue loans at a lower rate is something that prevented a lot of providers from potentially, utilizing said loans. So I think in this financial space, it would be good that if we can figure out a way that whether it be public health emergency or just to figure out a way that these types of advanced payments can be done in a manner that's not carrying such a significant interest rate.
Yeah, and it seemed like the feds kind of reacted to what happened rather than having sort of a game plan in place that they put into effect, like a public health emergency. And to Danielle's point, having a blanket set of waivers that they could immediately press go to would streamline things rather than piecemeal or delayed weeks or months. To have a plan in place and Terry, maybe to realize that it's a public health emergency and not tack on this 13% surcharge. And again, to Stanley's point, the whole center of this is to make sure that patient care is not impacted. And so to take all of those steps necessary. So excellent points. If we can go to the next slide, we're running out of time a little bit, but we've got a few more points we wanted to discuss. And this basically gets into what Danielle had mentioned earlier. I think it applies both to payers and providers by giving them a pass on some of the data reporting requirements. If we go to the next slide. So here's one that I wanted to float by folks, and that is there's a lot of federal agencies that have their fingers in the cyber pie. And is there a need to have what I would call a cyber czar, somebody I know, and Janice says, isn't that the role of CISA? But my understanding was CISA really didn't act with any rapidity during this cyber incident. So we need to have somebody with enough authority that they can press go on the waivers, that they can move payments to providers, that they can take the actions that are necessary. And it also bleeds into our next issue. And go ahead, Michael, if you want. And that is, could someone like a cyber czar be responsible for driving this idea of a national fire drill where we would take a week and it would give trading partners the opportunity, really the excuse, to go ahead and talk about contingency planning, develop some protocols, put them in place. And again, Terry and Stephen, correct me if I'm wrong, but don't hospitals have these sort of fire drills for mass casualties and things like that? And so if something, God forbid, happens, at least they have some processes in place.
Yes, they absolutely do. They have mass casualty events that they work with multiple agencies, local law enforcement, National Guard, depending on the trauma level designation you have in the hospital, you may be doing work with Coast Guard or, somebody else for like medevac tests. So in fact, interestingly, you say that because when we met with HHS and CISA, we had recommended this last year, that I said, look at the model that hospitals have to follow for mass casualty events and trauma events. And do something similar for cyber events, right? Because again, you're falling into a natural pattern and test practice that hospitals are good at. But I want to touch on for a second the CISA piece. I don't feel like CISA is the right organization for this. They actually just my review of the CIRCIA guidelines and looking at CISA's general approach, and I'll give them credit. They really are openly asking for feedback and trying to be good partners. But their understanding of healthcare is just so limited, right? They just don't understand how it works. And I think that's generally true with most areas, right? Like I feel like what makes more sense would be a cyber division within HHS to kind of help bolster OCR, which you already have. OCR, I mean, the rules are going back to regulations already exist. So stuff already exists. You have HIPAA, which is managed by OCR, is enforced by OCR. I say look at areas inside of HHS or inside OCR where they're lacking expertise or lacking staffing resources, and let's bolster that. But creating a master organization just hasn't worked so far. I mean, CISA lacks expertise in any of the specific areas. And I think that if you were on a call with people from the financial services industry, transportation, energy, they would say the same thing, right? So I think that more likely, I think the better path would be, let's help HHS get the resources, and help them work through what are the kinds of resources that they need to make sense. And I think that's probably where it would make the most sense.
Great point. Stanley, we're going to give you the last word here.
Well, the last word will be cost. I mean, the question is, unfortunately, who pays for this? There have been surveys out there that says the healthcare industry is woefully lacking in their investment in cybersecurity. We all know that Stephen, you're saying no, and Mike's saying yes. I'm not sure who to believe, but I mean, we've seen the result of this. What happens when there's a cyber attack? But the complaint has been, well, we don't have the money to spend on it. We're barely getting by, and the federal government doesn't have the resources to do that. So I don't know how you balance costs. People have said, make this. Get a refund on Medicare or Medicaid, do other things. We need to figure out a way to encourage the industry and the government and do that. We need to have some way to encourage the industry and the government to increase their investment in cybersecurity without necessarily coming up with the bucks ourselves. Thanks.
So a sobering last statement, Stanley. No, but very important. So we've come to the end. If you go to the
Is anyone else having problems with Rob's audio?
I think that's
Yes,
Rob's audio. He's lagging a
Yes.
little bit. All right. Give him a second. I think what Rob wanted to say is promote our next upcoming event. Oh, are you there, Rob?
Yeah.
Yes,
So
but
I
your
did
audio is
want
not
to,
clear, Rob.
just
Yeah,
make
the
folks
network
available.
is still failing you,
Oh,
Rob.
Sorry.
Oh,
That's
you're back. You're
my
back.
house was hit by a cyber incident. Okay.
I think you're good.
Yeah. Am I back?
You're in and out.
Let folks know. Okay. I'll be brief then. Spring conference, we discussed that, going to take place 13th to the 16th. Cybersecurity will be one of the topics we'll cover. And I wanted just to thank a few folks. I wanted to thank our wonderful facilitators, Leslie, Tantian, Danielle, Terry, Beth, Stanley, Stephen, Pam, as always, to my colleague, Michael McNutt, for all of his hard work behind the scenes making all this happen. If you have thoughts and comments on these issues you wanted to share, please reach out to me, rtenant@wedi.org. Happy to include those in our summation. Look for our output, which will be twofold. One, a letter to HHS recommending a number of actions, and two, a set of recommendations to both individual healthcare stakeholder groups and also sort of generic ones that would apply to all. So I'll be calling on some of you folks to help in the development of that. And with that, I want to thank you all for attending. It's been a great discussion. Unfortunately, it's only the beginning. I think we'll be discussing this issue for many, many years. So with that, we'll close the event. And again, thank you so much for being part of WEDI.
Thank you.